Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today I'm excited to be answering some of your top fertility questions, especially about ovulation. If you are new here, welcome to the As a Woman podcast. I created this podcast just so that you can learn about your body and be a better advocate for your own health and fertility. And I'm just so thankful for all the love and support that you have given. These are my favorite episodes, and this is where I answer your voicemail questions. So please call and leave your own question at 657-229-3672. Again, that is 657-229-3672. You can also ask questions on Instagram on Monday at nataliecrawfordmd or in the newsletter, nataliecrawfordmd.com/newsletter. Some of those questions will be answered on Instagram, here on the podcast, in the newsletter, or even on YouTube. If you haven't checked out the YouTube channel, just search Natalie Crawford MD. We are almost at 200,000 subscribers and short form bite-sized content videos. If that's your jam, head to YouTube. We're going to go ahead and dive on in. Today, these are your questions, mostly centering around ovulation and getting pregnant.
Hi, Dr. Crawford. I've really been enjoying the podcast, and I was hoping you could speak towards prolactinomas and high prolactin levels after pregnancy is confirmed. A little background, I'm 30 years old, and I'm in the beginning stages of my trying to conceive journey. I was diagnosed with a prolactin-producing pituitary tumor with extremely high prolactin levels 7 years ago when I was 23. I was completely amenorrheic, having no periods, but within a month of being put on cabergoline, I started having very regular periods and no problems, which was really encouraging. I've been tracking LH with OPKs and do seem to be ovulating regularly. My endocrinologist and midwife both recommend to keep taking the cabergoline until I conceive and then stopping immediately once a pregnancy is confirmed. I was wondering how high prolactin levels interact with progesterone and other hormones. If the prolactin levels rise after I stop the cabergoline, could that lead to miscarriage or any other problems? Thank you for taking my question.
I think this is such a great question that highlights a few different points. So number one, prolactin is one of those things that can definitely cause irregular or absent periods that very often is dismissed. So I'm so glad you got this diagnosed when you were so young. For everybody who's listening, I'll get to the answer to the question, but just to kind of think about it, prolactin comes from the pituitary gland. If we remember, also from the pituitary gland are the hormones FSH and LH, which are important in ovulation. So the brain, the pituitary, sends out FSH, follicle-stimulating hormone, which gets a follicle to grow. And as that follicle grows, that's when you make estrogen. Once that estrogen gets to a high enough level and it's mature, then the brain will send out LH, and that is the signal to ovulate. After you ovulate, that follicle reforms, becomes the corpus luteum, and makes progesterone. Now, progesterone is very important in pregnancy and implantation. Progesterone opens and closes that implantation window, and the corpus luteum can only live about 12 to 14 days. And after this, it's going to die, progesterone will drop, and that will be the signal to the body to have a period. Now, if you get pregnant about a week after ovulation, this pregnancy is going to be arriving into the uterine cavity at the stage for implantation, and the pregnancy will start to invade into the uterine wall. The pregnancy then makes the pregnancy hormone, which is called HCG, human chorionic gonadotropin. HCG, most people are familiar with because it's what you check when you take a pregnancy test. And when you take a pregnancy test, if you've ever taken an early one, or if you've ever seen anybody showing their series of pregnancy tests, you know that they get darker over time. And this is because as that pregnancy grows, HCG is made at an exponentially increasing level, and it's constantly made. So unlike the corpus luteum, when it was under response from the brain, and the brain stimulated the corpus luteum to make progesterone in pulses, correlating with the LH pulses from the brain, now the pregnancy is going to come in and have this constant and increasing stimulus, and you are going to see this constant rise of progesterone. Okay, so that's just the normal ovulatory process. When the pituitary gland is making prolactin, and it can make too much prolactin for a few different reasons, but a pituitary adenoma is a more common one. This is essentially a pituitary mass made of the type of cells in the pituitary where prolactin is made. Pituitary is so fascinating. It actually is mapped, meaning think of it like a continent and there's different countries, and in those different countries, that is where different hormones are made. So FSH and LH come from one area, TSH from your thyroid comes from another, prolactin comes from another. And when you have this mass making prolactin and being stimulated, all of the attention is going there, and none of the attention is going to the area of the pituitary where FSH and LH come from. So what happens, and this is so fascinating, is as prolactin rises, you have a graduated change in your ovulatory pattern that's really pretty distinct. So mildly elevated, you'll start to see short luteal phase. So what happens is now, because that prolactin is a little high, just the LH signals aren't quite strong enough to make as much progesterone, and the corpus luteum dies faster. You're still ovulating, so there's still FSH, there's still LH, it's just a dysfunctional zone. Now as prolactin gets even higher at moderate levels, well, now we're seeing irregular cycles, so that FSH is not coming as reliably, and now we're ovulating at a really irregular pattern. And then when it gets even higher, prolactin is now at a point where all of the focus of the pituitary gland is on pumping out prolactin, and no FSH is made, resulting in no ovulation at all and amenorrhea, or lack of a period. And in this case, you also have low estrogen levels because you're not ovulating at all. And so the symptoms here are those associated with low estrogen, fatigue, brain fog, hot flashes, difficulty sleeping, low libido, vaginal dryness. And as you treat your prolactin, these levels are going to go back down, and you'll see a reverse in this ovulatory dysfunction. When you have a prolactinoma, so a mass in the pituitary gland, there are microadenomas that are little, there are macroadenomas that are bigger. That is all about the size of the mass, not about the amount of hormone it makes. The importance here is your treatment plan once you're pregnant is going to differ, sometimes based on the size or the type of mass that you have. Microadenomas are much more common, they're very small. In these, our recommendation is exactly what you have heard. So when you have high prolactin, we're going to treat you with a medication called a dopamine agonist, and this essentially blocks the production of prolactin. Your prolactin will, over time, get back to that normal range, and your ovulatory pattern should resume. Fantastic. It sounds like that's happened. I believe you. You're getting your ovulation tests that are positive. When you get pregnant, the recommendation is to stop that dopamine agonist. And your question's a good one. You're fearful that if I stop this, is now my body not going to be able to make progesterone? And is this going to cause me to have a luteal issue or cause me to have a miscarriage? Remember that pregnancy is happening in the middle of the luteal phase. So about a week after ovulation, that pregnancy is implanting, and now you're making HCG. So that corpus luteum is no longer reliant on those LH pulses from the brain. Also, because at that point, the corpus luteum is no longer going to be under brain stimulus by the time you take a pregnancy test anyway. And the dopamine agonist, the bromocriptine, or the cabergoline are not going to interfere with the pregnancy's production of HCG, thus stimulating progesterone. In fact, prolactin is actually important in pregnancy. It is a regulator of growth, and prolactin levels get really, really high in pregnancy. So we want your body to be able to do that. So you should feel comfortable stopping the medication along with the positive pregnancy test and not worry that you're going to cause any harm to the pregnancy. Now, the one caveat or exception here is if you potentially have a macroadenoma. One of the fears with macroadenomas, because of where the pituitary is if they get really big, they can actually press on your optic nerves and impair your vision. That's why having tunnel vision, headaches can be a very bad sign if you have a prolactinoma, or if you're having period changes associated with headaches and vision changes. Please do not pass go. You need to get an evaluation immediately. Management of macroadenomas can be different. Sometimes surgery is recommended. Often a trial of dopamine agonists is first. Often the recommendation will be to stop the medications if you're pregnant and follow for symptoms. But because you can't just check prolactin levels, does that mean visual field tests or MRI? And some people, based on the size, they might recommend that for that person, it is safer to stay on the medication. So that would be the more of the exception versus the rule. And the very standard rule is once you see that positive pregnancy test, to stop that prolactin-lowering medication. All right, and moving on to our next question.
Hi, Dr. Crawford. Love listening to your podcast. Question for you. I am realizing that I frequently get bleeding either the day after or the day of ovulation. Does this mean that I can't get pregnant, and why am I bleeding while ovulating? Thanks.
All right, so when you ovulate, we already talked about the fact that the follicle ruptures, allowing the egg to be released. The cells around this follicle are actually the cells that are making estrogen, not the egg themselves. As the egg matures, the follicle gets bigger, the cells are more active, estrogen levels raise to those peak levels that then go ahead and trigger ovulation. At that same time, with those peak levels, we see a change in cervical mucus. You'll see that type 4 sticky cervical mucus. Often you'll notice an increase in libido, and all of that is from the peak estrogen. Well, after the follicle ruptures, the cells that are making estrogen, some of them are disturbed because they're broken open. The follicle will reform after ovulation and make the corpus luteum. And the corpus luteum, we always talk about that it makes progesterone, but it also makes estrogen as well. So what happens is that you'll have a transient dip in your estrogen right around the time of that follicle rupturing, around that time of ovulation. And some people are just super sensitive to this. And that transient dip causes an estrogen drop, and your body feels this and might have some bleeding because of it. However, progesterone is going to be produced soon thereafter, and progesterone stabilizes the endometrial lining. So periovulatory spotting is not something that's going to prevent pregnancy. It shouldn't be heavy like a period. It shouldn't be clotty. It's classically thought of to be very light, could be even pink, brown, or red, but very, very light and very transient in nature, typically lasting 1 day, at very most would be 2. If you're having more than that, then I'm more concerned that maybe there's something else going on. But if it's very classic and in that pattern, then this sounds like ovulation-related spotting from the granulosa cells being disrupted at ovulation. Not an issue. A quick reminder, if you want to call and ask your question, it is 657-229-3672.
Hi, Dr. Crawford. I am just calling in to ask a question about PCOS and absence of a normal period. So I have PCOS and I do not ever get my period. And when my husband and I want to start trying to conceive, I was just wondering how long on average that may take for somebody like me. Everything with my husband and I is normal. Otherwise, all of my labs are normal. I've kind of done a ton of pre-work beforehand. But really just curious, once we start in that, how long it will take and what are the chances and odds for somebody who's using an ovulation induction medication to help them conceive and to help them ovulate? I just haven't found a whole lot out there about absence of a period and success stories with trying to conceive. So just would like to know a little bit more about that. Thank you so much.
All right, for PCOS, I always like to reference back to my vault analogy. If you haven't heard it, you're born with all the eggs you're ever going to have in a vault. Every single month you have a group of eggs coming out, and from that group, one is chosen to ovulate and the rest die. PCOS in general is being born with too many eggs. Because you're born with too many, the vault sends out more every month because the number that come out of the vault is proportional to how many remain inside. When you have that high egg number outside the vault, the brain doesn't know that and sends out its normal amount of FSH. That normal amount of FSH is then diluted amongst all of these follicles, and it's not a strong enough signal to get any follicle to grow. And this can cause various stages of menstrual abnormalities. You might have regular periods. You might have irregular cycles. You might have no period at all, like this listener. PCOS is diagnosed by having 2 out of 3, 1 being seeing a high number of follicles, 2 being menstrual changes, and 3 being signs of high androgen levels. Because as the ovary is not ovulating and making estrogen, it gets really bored and its focus shifts and it starts making testosterone, which then causes hair growth on your face, hair balding from your head, acne, and other undesirable symptoms. For PCOS, typically what we do when we try to get somebody pregnant is we will use ovulation induction medications. There are different options to induce somebody to ovulate. One option are oral medications. One is Clomid, one is letrozole. These both work slightly differently, but the general premise is they lower your baseline estrogen levels. The brain is supposed to sense this drop in estrogen and send out a stronger signal of FSH. Now, because each egg makes a tiny bit of estrogen, if you have more eggs in the ovaries, so if you have PCOS and you have 40 antral follicles instead of your age-related normal at 20, you have a baseline higher estrogen level, and that is prohibiting the brain from really understanding that an egg isn't growing. When that estrogen drops, because Clomid blocks estrogen receptors and letrozole eats estrogen up in your bloodstream, the brain suddenly says, oh my gosh, I have less estrogen. I'm going to send out more FSH. This is an indirect pathway, meaning number 1, I'm relying on your brain to interpret this. Number 2, I don't control how much it sends out. Number 3, I don't control if that's enough to get just one egg to grow and not too many eggs. And number 4, you've lost the brain-ovary communication. So that feedback system is broken. Outside of oral agents, there are injectable options, which is giving your body FSH. And FSH is obviously the more direct pathway, but it can be more expensive, harder to titrate, and has a high rate of multiples and canceled cycles. A lot of people with PCOS, their practice might not offer that, or they might recommend you skip that option and go to IVF if that's the case. This is a very personalized decision based on sperm counts, age, number of kids you want, your AMH, what other treatments you've tried, do you have no periods or some periods? So there's not going to be a one size fits all, but here are some of my basic thoughts. Number 1, always recommend full testing. Are your fallopian tubes open? Is the sperm normal? Have you checked the other hormones that are also associated with PCOS, prediabetes, thyroid disease? Number 2, if you have PCOS and hypothalamic amenorrhea, you're not going to respond to oral medications. It's going to be frustrating. I definitely have had patients like this in my career, and they often think they just have PCOS, but it also turns out there's a hypothalamic component, meaning the brain is also shut off because of stressors, and whether that's weight loss or calorie restriction or chronic illness or inflammation or autoimmune disease, variety of different things. You can have 2 things going on at once. A classic PCOS blood panel is going to show a normal FSH level, potentially a high LH, a higher estrogen than normal, and typically a higher testosterone or on the high end of the normal range. If your blood work is coming back with a low estrogen, low FSH, low LH, I've got concerns that you might have hypo and would definitely want to be having a discussion about this. Now, let's say we don't have that. If I can get you to ovulate with letrozole or Clomid and you're ovulating 1 egg, you have your age-related chance of getting pregnant. This means the younger you are, the higher those odds are going to be. Even though infertility is officially diagnosed as 1 year of trying to get pregnant without being able to do so, that is 1 year of regular cycles with intercourse. So if you have PCOS and you have no period, you're going to have to induce every single one of those cycles. However, almost 75% of people are going to be pregnant after 6 months. So for my anovulatory PCOS patients with a totally normal workup, if we are not pregnant after 5 or 6 cycles of ovulation induction, I'm saying, hey, something else is going on. Do we have unexplained infertility? Why has this not worked? Also, because the risk with all these medications is either no response, or over response, this can be very frustrating when done without monitoring. Sometimes it's so easy. So I don't think it's wrong at all if you go see your OBGYN and they want to give you a low dose letrozole and they tell you to have sex or to check a progesterone or to check ovulation tests. But if those things are confirming that you are not ovulating, you're going to know this because you're going to have to take progesterone to get your next period. I would not do that over and over again. It's going to be so frustrating. I would then go see a fertility clinic or ask your OB if they have the capability to do ultrasound monitoring to see if you actually respond. Some patients with PCOS will also have a hard time ovulating or a hard time making enough progesterone. So my favorite is going to be do your fertility testing. If all things are as we think they are, proceed with letrozole for ovulation induction that has the highest live birth rates for PCOS, monitored with ultrasound. I like to use a trigger shot, tell you when to have sex, and then take progesterone in the luteal phase. The nice thing about ultrasound monitoring is if you are in fact not ovulating and I see that, I can immediately stair step up your dose and try to see if I can get you to an ovulatory dose. The higher your egg count is, the higher your AMH is, the worse your menstrual dysfunction is. Having less than 3 periods a year puts you in a higher probability group of not responding to oral ovulation induction agents, being refractory, meaning those medications aren't enough to get you to ovulate, or over responding. So sometimes you just can't get into the perfect spot, and sometimes we have to move on to IVF for this reason. There's a lot of other components that play with PCOS. So if you're overweight, fat cells can make estrogen. Losing weight can help because it does lower that basal estrogen. That alone can restore ovulation in some patients, but in others, it can help you respond better to medications. Insulin resistance is a huge part of this. Testosterone being made from the ovaries contributes to this nasty cycle of insulin resistance. Essentially, your cells cannot uptake the sugar that's in them, so your body starts making more insulin since insulin helps control getting sugar into your cells, and you get into this pathway where you're just very sugar high, but your cells feel starved. That's associated with a lot of inflammation and is very harmful to your body for a multitude of reasons. But this is why decreasing inflammation and really trying to eat a healthy, balanced diet, less added sugars, less processed foods, more fiber and fruits and vegetables is really going to be a helpful part with PCOS. So I think that if we have our workup, everything else is fine, there's a good chance you will ovulate to your oral ovulation induction medication and be able to get pregnant. PCOS patients do have a slightly higher risk for miscarriage, probably more associated either with being overweight or insulin resistant if they fall into those categories. So decreasing inflammation and focusing on lifestyle modifications, even if you're doing fertility treatment, can be very helpful. And that's why you also see, in addition to just lifestyle stuff, for insulin resistance, you'll hear talk about metformin or inositol, and that can be very helpful. PCOS is really complex, and I have a lot of episodes dedicated solely to PCOS, but hopefully this helped give you a little bit of insight on what to expect with trying to induce ovulation as you proceed on your TTC journey. All right, and moving on to our last question.
Hello, I just finished my first cycle on letrozole. I did 3 rounds back to back, got a mature follicle in the last round. And then 7 days later, got a progesterone test, and it was less than 1. However, I started my period the next day. So what I'm wondering is a progesterone less than 3 would indicate that I did not ovulate, but the period obviously indicates that I did. So is it likely that I ovulated on one of the first 2 rounds, so potentially 5 to 7 days prior than we thought I did? Or is it possible to have a period without having ovulated? I know it's a tricky one, but would really, really appreciate an answer. Thank you so much for all you do.
This is a great add-on to how do we know if ovulation induction medications are working and what are the different ways to determine ovulation. So one thing that was mentioned here was a progesterone level. This is affectionately called a day 21 progesterone, and it's a terrible name. We should call it a mid-luteal progesterone. A mid-luteal progesterone means it's in the middle of the luteal phase, should be approximately 1 week after ovulation or 1 week before your next period, because the luteal phase should be about 2 weeks long. If your progesterone level was the day before your period started, I am not at all surprised that it's less than 1, because what causes a period to come? A drop in progesterone. Not low progesterone, but a drop. Which does tell me that you did in fact ovulate, and my crystal ball suspicion would be that it was just earlier than you thought by at least a week. Now, when you're doing ultrasound monitoring, you can see a follicle, but you don't always know if you come in for just one scan if that follicle is already newly ovulated or if it's going to ovulate. And there's definitely a chance at the time period they saw a follicle, it was already either in the ovulatory pathway or an early corpus luteum. I would suspect you ovulated around 12 to 13 days before you had that progesterone level drawn, which might mean you ovulated quite soon after having that letrozole. Now, depending on what happened in the month before, one thing that could have happened is you think you didn't respond. Did you take progesterone? Did you not? Sometimes if you had a progesterone level drawn that was at a later stage, or you were taking progesterone, that might not be enough to suppress the brain from starting to grow that next egg. So you can definitely miss your window, because what you see visibly as day 1 with bleeding is not representative of a day 1 ovarian stage. So potentially you ovulated in the cycle before and it shifted your ovarian window. Alternatively, you took progesterone, so you thought this was day 1, but really your ovaries had already started the pathway of growing an egg. And when you took the letrozole, they were already partway there. Maybe it accelerated the process. Another option is sometimes with ovulation induction medications, your body just ramps up sending out that FSH so fast and you ovulate sooner. So it could simply be just a mistimed option. That can be really, really frustrating. I always recommend, if I see you, I like to bring patients in for baseline ultrasound before we give letrozole. I like to do earlier mid-cycle scans, and we could do them a couple times if we're not sure. Other things to think about are, what about all the other signs of fertility markers? The things like the cervical mucus, or have you tracked your body temperature, or have you tried ovulation kits? These things, although they can be frustrating when you're not ovulating, and certainly sometimes when you're seeing a fertility clinic and we're inducing ovulation, you don't need to track them. But in this case, where it sounds like your OB kind of gave you medication and let you go wild, was just checking some progesterone levels, these other markers like temp tracking or OPKs or cervical mucus can help you have a better idea of when you did in fact ovulate. You did ovulate, you got the period, your progesterone was low, indicating a drop. Now it's just trying to understand when that actually happened and why was that different than what you determined. Ultimately, it's a good sign you ovulated with letrozole. Tracking your cycles can be really beneficial to get a good idea of when they're happening. Also, though, just having unprotected sex. So once your period stops, have unprotected sex. Maybe it doesn't matter as much when you exactly ovulate. If you are having intercourse 2 to 3 times a week, 2 or 3 days apart, you are covering your bases and there is sperm there at all times when an egg is released. Because an egg can live for 24 hours, but sperm can live for up to 5 days in the cervix. So understanding when you ovulate can be really important. But you can still get pregnant without knowing that, as long as you are in fact ovulating. But hopefully this helped you understand that a day 21 progesterone is really a terrible name. And you're right that it should be at a level of 3 or higher about 1 week after ovulation, and it can range anywhere from 3 to 40, and it's a perfectly appropriate value. But we expect that number to drop after that 1 week as you get closer to that period coming. And obviously in this case, it was just checked too soon to when that period was going to start, or too late after you had actually ovulated. But you did respond, so that's wonderful news. I hope this episode helped give you some information about ovulation and some of the top questions that we are seeing. As always, I'm so thankful to have you here and love answering your questions. You can ask questions over on Instagram at nataliecrawfordmd. Questions will be answered on Instagram, on YouTube, on the newsletter, and here. You can also call and get your questions answered from the voicemail at 657-229-3672. As always, thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.